Hi everyone, this is Neel Raithatha, consultant audiologist and director of WAX. Thank you for joining me in my latest video using the WAXscope. And here we have a patient who attended with bilateral, fully occluding wax plugs. And I'm just commencing with their left ear first, which is the more troublesome ear out of the two. And the reason why this ear was a bit more tricky, and you may have just noticed it at the beginning of the procedure, is that the entrance to the ear canal was extremely narrow, almost collapsed. So I'm using our medium-sized specular to dilate the ear canal. Once we've dilated it, the ear canal is a reasonable size, although, and you will see that again near the end of the procedure of their left ear, the anterior canal wall, so the front section of the ear canal, so in this case it will be the left-hand side, it is somewhat protruding, more than the norm. Now, most of our ear canals, the anterior canal walls are the front part. So if it's the right ear, it'd be the right side, left ear, the left-hand side of the ear canal. In the midsection, so the region we call the pars media, it does somewhat protrude more into the midline of the ear canal. But in this patient, it's a bit more prominent. And the difficulty caused by that is that we're trying to navigate this wax plug around that protrusion. Fortunately for me, I've seen this patient on several occasions, so I'm aware of their ear canal anatomy, and that does help during the procedure because I know which way to manipulate this wax. So I've removed the southern hemisphere, if you like, of the wax plug. I'm just going to the top bit here, and I'm just giving it a wriggle. I want to detach this from the canal wall, but it had this strange consistency where it was too soft for, although when I removed it, it looked quite firm, but when I used the ear hook, which you'll see in a moment, it just dissected straight through the center of this. And when I used the correct, it just spread the plug, almost like jam or butter on your slice of toast in the morning. So although the outer surface is a bit firm and crystallized, the core of the plug was quite soft and mushy. And what I'm trying to do here is separate this from the back part of the ear canal and the floor of the ear canal. So I'm just giving it, again, some wriggles. I've just used some medical grade olive oil spray just to help soften the surface of this plug so I can obtain a better airtight seal, which then leads to a much stronger suction grip. I can feel it's just trapped here on the back part of the ear canal. And you can see there's a bit of thick blanket of skin here, which is enveloped around the plug, and it's still semi-adhered to the canal wall. So we want to loosen that. You can probably tell the wax here to the right is a bit darker than the wax to the left. So I'm bringing this forward. So this wax has actually probably been in the ear for a bit longer. It originated a bit deeper in the ear, but I'm bringing it forwards. But you can see the difference in contrast. And the reason why I'm bringing it here, I'm trying to meander it from right to left because of that protrusion I made reference to earlier. So to the right, that flesh, that's the first bend, so we're nearing the entrance. It may seem like slow progress, but we are slowly but surely bringing this out. So I decided at this stage to introduce the ear hook, I believe. This is a bit of an opening at the top. Glided it in, rotated the hook, slowly brought it forwards, and it just cut through it like a hot knife through butter. So once again, I'm just dilating the ear canal again. Gone back in with the suction. So despite the hook not retrieving much wax, it has somewhat facilitated removal. When you cut through the middle, it gives you more wriggle room. So as you can see, I'm trying to bring this from right to left. So there's a bit more space created in the core of the plug where I can start manipulating this wax. With those hairs, they are just at the entrance of the first bend. So by virtue of the fact they're more visible means that we are bringing it forwards. So I've got a decent suction grip here, and I'm just giving it quite aggressive wriggles, just trying to squeeze this through the entrance. Now, when the wax comes this far near the entrance, I'm obviously having to just remove the WAXscope from the ear. Otherwise, you'd just be squashing the wax further in. So I'm just trying to open it as much as possible, but without squashing that wax back in. I think I'm going to use the correct in a moment. So this wax, because I removed that outer surface, it's become quite soft and mushy. So I'm just going to stretch the ear open. And then again, I'm just using those wriggle movements. I'm just trying to lift it up as well, because I can feel a bit, when you're performing the procedure, you can feel where this plug needs to be manipulated and maneuvered, and I can just feel I need to lift it up somewhat on the floor. So again, I'm just reaching out to the roof of the ear canal. I've just got the right correct over and beyond. I'm going to start scooping this, and I was hoping it was going to come out in a big plug, but as you can see, it's just separated and spread this soft wax all against the floor of the ear canal. So I'm going to go back in with the suction, lift it up again. And then I'm going to slowly tease this out so it's on its way. So in a moment, we're going to examine the ear, and you'll see that prominent anterior canal wall. Now, the patient did dislocate their jaw on this side. It was a footballing accident many years ago. And the temporomandibular joint, to the TMJ, is adjacent, probably about 1 centimetre into the ear canal, to the anterior canal wall. So I'm not sure if there was any fracture of the bone of the anterior canal wall in this region. So you can see to the left that bone protruding outwards. So this is their right ear. It is a narrow ear, but in comparison to their right, it's a lot. It makes it look like a large ear, so I can easily dilate this ear canal. I have got a video, another one I performed today with the WAXscope, of a lady with an extremely narrow ear canal. And again, it was a good test for the WAXscope, so it may not make the best viewing pleasure, but it's the reason why, one of the reasons why we developed the WAXscope, because some people struggle when you're using an endoscope and you've got narrow bendy ears, because you don't have the luxury of a specular like you have here. So that on the periphery of the screen, you can see that black shaded object. That's the specular. That's what we normally use to examine your ear. So when I first trained to become an audiologist, we use an otoscope, which is like an ear torch, and we attach a specular into to the end of it, which then enters the ear. And the aim of the specular is to dilate and straighten the ear canal. So with an endoscope, you don't have a specular, so you're having to use the side of the endoscope to stretch and dilate the ear canal. So with patients with narrow bendy ears, for people who struggle with the technique, they probably wouldn't be able to use an endoscope. Ironically, I find it somewhat easier, like it's probably the way I've been using it for years now, to stretch and dilate an ear with an endoscope. But this is the reason why we do like the WAXscope. It's more user-friendly for those types of ears. So I'm just mopping up some sticky wax just at the second bend there. You can see the ear canal's a lot wider here. That's the eardrum. It looks nice and healthy. So the anterior canal wall there is slightly protruding as well, but nowhere near as much as their first left ear. They're the two wax plugs. I think the bottom one is their left ear and the top one is their right ear. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.